So drag the word into the correct box. A type of anemia resulting from abnormal utilization of iron during erythropoiesis. Sideroblastic. Okay, this one we need to know at least some bit of this. When it comes to the anemias, we know anemias can be classified on different bases. Can look at the cause. You can look at some of them are classified as nutritional anemias, others you can classify them looking at the size and such. But then sideroblastic anemia, you have got iron is there, but then the cells can't utilize iron. That's sideroblastic anemia. Now my question is, when it comes to iron, imagine someone doesn't have iron. What type of anemia are they most likely to have? Of course, the iron deficiency anemia, like the cells, the size of the cells, are they big, small, normal? They are microcytes. Thank you so much. And then another thing, what conditions are more likely going to cause iron deficiency anemia? Any, yes. Mhm. Thank you so much. So basically, any condition that leads to loss of blood. So if someone presents with iron deficiency anemia, they are not bleeding, you should properly investigate. It means that they might have an internal bleeding, because it's the basic way in which you can lose iron. Besides that, some rare other cases in which you can have iron deficiency anemia is that you are not taking enough iron, or maybe you are losing iron there is no absorption of iron. So those are the some of them. It, and then when it comes to the to macrocytic anemia, we know that is caused by deficiency of vitamin B12 and deficiency of iron. Sorry, of folic acid. But I want to ask a specific question on vitamin B12. What can cause deficiency of vitamin B12? Lack of, thank you so much, lack of intrinsic factor. And then how can we lack the same intrinsic factor? Thank you so much. Yes. So gastrectomy, you've removed the stomach, and you know the stomach is where you have got parietal cells which produces intrinsic factor. So there's going to be a problem. Now, besides gastrectomy, what other condition can lead to to this B12 vitamin B12 deficiency? Thank you so much, Doc. Why? Thank you so much. Absorption of vitamin B12 happens in the terminal ileum. So resection of the terminal ileum means you can't. And that's known as pernicious anemia, where you don't have vitamin B12. So a type of anemia due to reduced vitamin B12 absorption or lack of intrinsic factor is pernicious anemia. Okay. Now imagine you gave an antibiotic, and that antibiotic resulted into anemia. What type of anemia is, which nutrient do you think has really caused that type of anemia? Like an antibiotic. Hope you can relate. When you imagine you are treating someone with an antibiotic, or say someone has got malaria, right? And then they present with anemia. Now, you know, anemia can be because of, let me not even give malaria, because for malaria, most of the drugs that we use to treat malaria cause anemia. But let's say just any bacterial infection, and then you give an antibiotic, and then the patient presents with anemia. More likely, which nutrient is missing for them to have that anemia? Iron. What's the thought? Antibiotics. Yes. If it's NSAIDs, we can of course yeah pick iron because of the ulcers. So you remember there's one class of antibiotics which work by inhibiting the folic acid pathway. If you remember the drugs, the methoxazole. So those drugs inhibit the folic acid pathway, and so they are going to likely cause megaloblastic anemia. A type of anemia with reduced red blood cells, macrocytic, we've already said that. Type of anemia in which patients with chronic kidney disease in patients with chronic kidney disease due to hypoproliferation from lack of erythropoietin. Can someone talk a bit about erythropoietin? How can lack of erythropoietin cause anemia? Or let's say, how can chronic kidney disease result in anemia? Anyone? Yes, that's a basic thing. So the kidneys are involved in production of erythropoietin, and when they are not working, it means that we don't have erythropoietin. And erythropoietin is actually necessary in the making of new red blood cells. So you are not losing any red blood cells. It's not like you lack nutrients. So it's all fine. So it's just that you don't have what it takes for you to make red blood cells. So the red blood cells are going to be normal in size. So those are going to be normocytic cells. So lack of erythropoietin causes normocytic anemia. A type of anemia caused by vitamin B12 and folic acid, we know that's megaloblastic. Hereditary hemoglobinopathy mainly affects people in Africa origin, marked by chronic hemolytic anemia. You know that's sickle cell. How does sickle cell disease cause hemolysis, hemolytic anemia? Anyone with a thought there? You know these cells have got an improper shape, right? Yes, doc, you can go on, please. Thank you so much. So you have got your red blood cells, they have got an improper shape, and as they are passing through these small capillaries, they can't force their way in those capillaries. And so what happens is that as they are forcing their way in the capillaries, they end up being broken and they end up being destroyed. So that's hemolysis. Okay. And then you can have some type of an imagine you have got a condition where you lack all the nutrients, like you don't have iron, you don't have vitamin B12, you don't have folic acid. Iron means that the cell is supposed to be small. Folic acid and vitamin B12 is supposed to be big. So now you have got a mixed anemia because of poor nutrition. For example, because like the iron, vitamin B12, and folic acid, they are mostly found in the liver. That's where they are stored. So for vegetarians or the vegans, there's no way they are going to eat a liver in rape or in catapa. So they are going to end up with this mixed anemia. An 18-year-old woman with a history of 4 years of chronic alcohol abuse presented to her first antenatal visit in her second trimester. She's moderately underweight, and the peripheral blood smear shows large red blood cells and hypersegmented neutrophils. The laboratory tests show mildly reduced red blood cells. and raised mean corpuscular volume. But serum ferritin and vitamin B12 levels are within normal range. What type of anemia does she have, and which drug would you prescribe? Folic acid, right? Thank you. So just some terms. We have got these two terms, MCV, mean corpuscular volume, and MCH, mean corpuscular hemoglobin. MCV tells us the size of the red blood cells, the average size of all the red blood cells. MCH, hemoglobin is the one which contains iron, and iron is the one that contains the color for the red blood cells, the red color. So MCH, mean corpuscular hemoglobin, is about color. So you talk of normochromic, hyperchromic, hypochromic. So in this condition, you can see from the analysis, the first thing is the alcohol abuse, and then peripheral smear shows hypersegmented neutrophils. And this is one thing that you need to take note about of megaloblastic anemia, specifically folic acid deficiency. You also have the neutrophils which are hypersegmented, but we've been told that we have got reduced red blood cell count, so that's anemia, and then raised mean corpuscular volume. That means it's megaloblastic. Ferritin and vitamin B12 is low. So for megaloblastic, there are only two choices, vitamin B12 and the folate. But B12 is normal, so it can't be. So it is megaloblastic anemia due to folic acid deficiency, so even the treatment you replace. A patient with a history of gastrectomy was in heart failure secondary to anemia. He has never received blood supplement injection. I'm forced to ask this question before even finishing this because I think it's an important one. What is a major problem that people might suffer after getting a blood transfusion? Let's say, for example, someone lacks iron and then you decide to do blood transfusion, or maybe some any other hematological condition and then you do transfusion. What problem are they like? Thank you so much. Iron overload. So with blood transfusion, iron overload. Because the thing is that when iron goes in the body, most of it is actually going to be stored and barely removed. So it's going to be an overload. So if laboratory results confirm megaloblastic anemia, why would the folic acid supplementation be contraindicated in this patient despite being a possible cause of megaloblastic anemia? Why not folic acid? Remember there is gastrectomy and we already said something. Anyone to help? Folic acid would take too long to reverse the neurological symptoms of vitamin B12 deficiency. Folic acid would mask hematological signs of vitamin B12 deficiency, which is the likely cause of the anemia. Patient has adequate store of folic acid because the body reuses it and little is lost. Folic acid may increase vitamin B12 metabolism due to increase the hematopoiesis. Thank you so much. So the best option is this one. Remember vitamin B12 and folic acid, they are all responsible for the same type of anemia. So when you replace vitamin B12, it will be helping. It will be helping a bit, but then it is masking the hematological signs, the problems, really, the actual problem, which is caused by lack of folate. So even when it is pretending to help, it will backfire. 46-year-old man with a history of resection of the small intestines presented with pallor and muscle weakness. The hemogram revealed a mildly reduced red blood cell count and raised mean corpuscular What's that? Mean corpuscular hemoglobin or volume. However, the serum vitamin B12 was elevated. So you see, this patient has got a resection of small intestine. B12 is high. Serum ferritin is normal. Diagnosed with megaloblastic anemia after 14 days of treatment, red blood cells were normal. Which treatment was prescribed? Vitamin B12, increased conversion of homocysteine to methionine, folic acid, increase in the of tetrahydrofolate, iron, increase in the of erythropoietin, folic acid, increased conversion of homocysteine to methionine. Any thought here? So this one, folic acid, because we've been told resection of the small intestine, obviously that should be the terminal ileum, so there's no absorption of vitamin B12. There's no, actually, even the if it was terminal ileum, vitamin B12 would be the problem. But we've been told that vitamin B12 is not okay. Still, the absorption of folic acid also needs the ileum. So if there's a resection of the ileum, so not just the ileum but the small intestine, if there's a resection of the small intestines, that will still make a deficiency, because for this problem, vitamin B12 is high, meaning that's not a problem. So it is folic acid. And folic acid, for it to be active, you need to convert it to the active form, which is it tetrahydrofolic acid, tetrahydrofolate. 53-year-old man recently diagnosed with pernicious anemia started treatment with vitamin B12. Which of the following molecular actions most likely mediated the anti-anemic effect of this or the drug in this patient? Demethylation of methyl tetrahydrofolate, formation of DNA along with the folic acid, hydroxylation of tetrahydrofolic acid, absorption of folic acid. In other words, what is the mechanism of action for vitamin B12, isn't it? That's the question. Anyone? So the answer is still D, methylation of methyl tetrahydrofolate. Actually, vitamin B12, when it is taken, it will still go and help folic acid. Okay. So there's going to be demethylation of the methylated tetrahydrofolate. That's how the vitamin B12 works. The blood results of an elderly male patient shows a red blood cell count of 3, and you see that's low, that's anemia. Mean corpuscular volume MCV is 115. MCV is high, so you can think of megaloblastic. Vitamin B12 is 90. You can see B12 is low. Ferritin is 250. That's normal. What are your diagnosis and most appropriate drug? So we have seen that the problem here is vitamin B12. Microcytic anemia, ferrous sulfate. Megaloblastic anemia, folic acid. Pernicious anemia, cyanocobalamin, microcytic. And you can see there's nothing else that we can pick, right? We can't pick microcytic. We can't pick megaloblastic due to folic acid. And we can't pick microcytic. It's actually pernicious anemia, lack of vitamin B12. And you give cyanocobalamin. Multiparous woman with malnutrition was admitted with symptoms of anemia. Pertinent laboratory values on admission were red blood cells 2.6, that's low, anemia. Mean corpuscular volume 90, that's low, so meaning that it's microcytic. Supposed to be microcytic, right? So let's see, mean corpuscular volume is 90. Okay, that's normal, so supposed to be normocytic. And then hemoglobin is 7.2. The number is supposed to be greater than 12, so meaning hemoglobin is low. HB is less. Ferritin is 7, so iron is less. And then RBC folate is 50, red blood cell folate 50, and you can see that is low. Peripheral smear shows microcytes and macrocytes, so this is a mixed anemia with hypochloremia. Which drug treatment would you prescribe? Erythropoietin and hydroxycobalamin, folic acid and ferrous sulfate, vitamin B12 and ferrous sulfate, folic acid and erythropoietin. Yes, thank you so much. So the problem is folic acid and iron, so we want to replace those. So I will give folic acid and the sulfate. 18-year-old woman with a history of 4 years of chronic alcohol abuse presented to for her first antenatal visit in her second trimester. She is moderately underweight and the peripheral blood smear shows large red blood cells and hypersegmented neutrophils. Most if you see hypersegmented neutrophils, think of folic acid deficiency. Laboratory tests show mild reduced red blood cells and raised mean corpuscular volume. Serum, and you can see vitamin B12 and iron are normal. So the problem is with folic acid, right? What type of anemia and what does she have and which drug would you prescribe? So we already did this one, eh? Megaloblastic folic acid. Patient with anemia with red blood cell 3.5, you can see that's low. Mean corpuscular volume is 94, that's normal. Hemoglobin is 7, that's low. So HB is low. Serum iron is 42, that's low. And then serum creatinine is 5, and you can see that is above normal. Show the following pairs of the drug, so meaning that there is a problem with the kidney. Which of the following would be the most appropriate to treat the patient? Folic acid and the oprilvecin, erythropoietin and filgrastim, folic acid and iron dextran, erythropoietin and ferrous sulfate. Why are we? Mhm. Thank you so much, Doc. So the ferrous sulfate is helping in replacing the iron, and because we've been told you can see serum creatinine is high, meaning there's a problem with the kidney. So meaning that if there's a problem with the kidney, it might not produce erythropoietin. So give erythropoietin to cause the production of red blood cells. A patient with anemia with red blood cell count 3.5, that's low. Mean corpuscular volume is 94, that's normal. Hemoglobin is low, so HB is low. Serum iron is 42, that's low also. Serum creatinine is 5. It's the same question? Okay. So it seems, yeah, this is the same question. Patient who complete chemotherapy may have autologous bone marrow transplantation. Which drug can be used to expedite neutrophil recovery? Oprivecin, filgrastim, leucovorin, cyanocobalamin. So it is filgrastim, right? There's a doc that gave us a nice mnemonic. We have got feel for the filgrastim with the feel from the neutrophil. So you can always remember that. And then would someone say something about this? When do we use the leucovorin? It's actually an antidote. To what? Anyone with an idea with that guy? Mm, pardon? Okay. So so just on this topic, if we can relate, when you give folic acid for someone that has got anemia, there are some drugs that inhibit the wake or the synthesis of folic acid. For example, drugs like methoxazole, those folic acid antagonists. So drugs that reduce, right? So drugs that reduce the production of folic acid, you can inhibit them by giving leucovorin. Oprivecin is a recombinant interleukin 11 recently approved in patients on chemotherapy in non-myeloid cancer patients with thrombocytopenia, which progenitor cell line has receptors that this drug attaches to produce its therapeutic effect. Specific white blood cells to produce neutrophils, erythrocytes to produce more red blood cells, megakaryocytes to stimulate the production of platelets, granulocytes to produce multiple white blood cells lines. So every time you see a question with interleukin 11 or pre elvecin, it's about production of platelets, and platelets come from megakaryocytes. A 36-year-old man with HIV-related chronic kidney disease undergoes hemodialysis. He is also on erythropoietin for normochromic normocytic anemia. He is on erythropoietin. His blood cell counts are within normal range. However, his hemoglobin is higher than expected, which common adverse effect. Okay, this one, do you even need options? Erythropoietin has got one adverse effect. You have got normal red blood cell count, but then high hemoglobin. That's known as thrombotic complication. 70-year-old man complained to her physician of bleeding gums secondary to thrombocytopenia. She is a cancer patient on chemo. Hemoglobin is 10 gram per deciliter. Neutrophil count is normal, but platelet count is a tenth of expected, so platelets are low. Which parental drug is most helpful? So we are just from mentioning on the previous question, interleukin 11 or Priovecin. 59-year-old male is on chemo for cancer. Unfortunately, an opportunistic infection infected his bone marrow when his immunity was low. Chemotherapy reduces the CD4 count. As a result, the white cell and neutrophil count were less than half the expected. So we have got less neutrophils. However, hemoglobin was mildly reduced but improved with hematinics. What is the patient's low neutrophil count, and what drug is most appropriate? So as we said, think of neutrophil with filgrastim. We know low neutrophil is neutropenia. An elderly patient with chronic arthritis on high dose ibuprofen presents. The laboratory results reveal reduced hemoglobin, mean corpuscular volume, and serum ferritin. What is the diagnosis and mechanism of action of the drug prescribed for the patient's condition? So look at the problem. Mean corpuscular volume, the laboratory review reduced. So there's a reduction in MCV and also reduction in iron. So without even looking at the options, what is the problem? Anyone? Iron deficiency anemia, macrocytic. And how can we treat that? How can we treat iron deficiency anemia? Simply replace, isn't it? So replace a chemical whose stores are severely depleted. And we need to be just watch out of the other options because this patient has got chronic kidney disease, I mean chronic arthritis. You would as well go for anemia of chronic infection or diseases. So for A saying anemia of chronic illness, stimulation of transferrin production by the liver. Now that's not a treatment there. I an iron deficiency anemia, activation of specific receptors on RBCs, that's not the mechanism. Anemia of chronic illness, stimulation of erythropoietin is not a mechanism. It's to replace the iron basically. An elderly patient is the same. Which option shows the body's largest and second largest iron stores? Okay, without looking at the options, what's the largest stores in the body? Anyone to help with that? Starts with F. Ferritin. No, ferritin can store iron, and you also have transferrin. Transferrin transports iron. The second largest is a hemosiderin. 40-year-old woman with a history of fibroid uterus with a long-standing menorrhagia. She has signs and symptoms of severe iron deficiency. Laboratory tests show reduced red blood cell count, mean corpuscular volume, hemoglobin, and serum ferritin. Which drug would you prescribe? We know there is low iron. So oral iron tablets will remove the ferroxamine because it's an antidote to iron. So we remain with these others. Again, normal when you just see iron dextra, you want to remove it because it has got a lot of side effects. That one, please. When you just see where treatment with iron is concerned, and then there's another option other than iron dextra, remove the dextra because of the sensitivity. Now, because in this condition, okay, let me not comment on that. So we now have two options, and why are we going for D and not A? Anyone with an idea there? And you can even see this condition is severe. So if something is severe, you don't want to be giving something that is oral because of the mechanism of action. So you would rather go for parenteral or iron sucrose. An elderly patient with microcytic anemia after a gastrectomy a few years ago, surgery was secondary to chronic non-healing peptic ulcer. So there was non-healing peptic ulcer and has got microcytic anemia. S- She presents with anemia despite having monthly cobalamin injection. The mean corpuscular volume, hemoglobin, and hematocrit 32% were mildly reduced. Which anti-anemic drug is the most appropriate? We already know the problem is with the iron because of microcytic. So we'll remove this. But then again, why have we decided to go for oral iron other than parenteral iron? Anyone that can help with there? Thank you so much. Thank you. So it's not severe, so we can go with the oral iron. A 24-year-old woman recently diagnosed with iron deficiency anemia started treatment. What is the mechanism of intestinal absorption of iron, oral iron? How do we absorb iron? Pinocytosis, endocytosis, exocytosis, or maybe ion channels? How do we absorb it? So you use active transport. You'll be transporting with some other compounds. An 8-year-old sickle cell disease patient with a history of vaso-occlusive crisis receives whole blood transfusion therapy. What is the expected complication and how can you manage it? Anyone to help? Thank you so much. There's iron overload, so you give the ferroxamine, which is the antidote. Which drug used in treating microcytic anemia may result in severe allergic reaction with associated cardiovascular collapse and anaphylactoid reaction? As we said, iron dextra is very bad because of these severe reactions. That's why you want to avoid it. A 5-year-old boy accidentally consumed his mother's iron tablet, which he mistook for sweets. As a result, he was admitted with abdominal pain and signs of acute stage iron poisoning. Which of the following drugs is mostly appropriate for prompt drug treatment and what is the mechanism of action? We already talked about the drug, deferoxamine. Deferoxamine is a chemical antagonist to iron. You know how chemicals interact. Does anyone wants to say what chemical antagonism is about? Thank you so much, Doc. So the ferroxamine is going to be able to bind the ion, and so the ion cannot go where it was supposed to go and bind. A 23-year-old woman with an autoimmune disorder is being treated with methotrexate after failing to respond to steroids. As a result, she is prone to folate deficiency and anemia due to methotrexate toxicity. Which drug should be given? Remember methotrexate. What drug is methotrexate? This is a drug that is an inhibitor of folic acid synthesis or function. So remember we said that you can use an antidote against those drugs that inhibit folic acid. That's leucovorin. A 13-year-old girl achieved MENAC with a heavy period 2 years ago. She is a vegetarian due to religious reasons. She complained of reduced mental alertness and the failing grades over the past 6 months. She is also too tired to participate in the sports that she used to excel in. Hemoglobin and mean corpuscular volume were mildly reduced. Serum ferritin was less than half the expected range. Which option gives the most correct, appropriate risk factor for a condition and drug treatment? So if you can, Thank you so much. So, for the fact that she menstruated, she lost iron. For the fact that she's a vegan, she just eats vegetables, there's nowhere to get iron because iron is from the liver, that's from animal. And so you can use the oral iron to get to treat her. So we are not using parenteral iron also in this case. Why aren't we using parenteral iron? Why didn't we go for the last option? So I can see there's just a mild reduction. 13-year-old girl achieved menarche. Is it not the same? It's different. With heavy periods 2 years ago, she is a vegetarian due to religious reasons. She is also too tired to participate and everything that way. The hemoglobin and mean corpuscular volume were mildly reduced. The serum ferritin was less than half. What is your diagnosis and which element is lost and lacking in a diet? So how did we tell it was microcytic anemia? Low iron levels, thank you. And we know iron is the one that is lost, isn't it? Actually, from the question we've been told there's low ferritin, which is the guy where iron is normally bound. 34-year-old woman recently diagnosed with iron deficiency anemia started treatment. Which of the following mechanisms was most likely involved in the delivery of iron to the patient's erythroblasts? Now you've seen the difference of questions. This is the delivery of the iron to the erythroblasts. Previous one that we read was the mechanism how iron is uptaken, and we said is by active transport. So as iron is entering the red blood cells, not really the red blood cells, but the blasts where red blood cells are going to be coming from, it is by the receptor mediated endocytosis. We differentiate it from the uptake of iron, the absorption of iron in the GIT, which is by active transport.